some shopkeeping. A CME code for today is a 31644. I'm Keith Kay. I'm the Division Chief for Allergy, Immunology, and Infectious Diseases, and it's my distinct pleasure to introduce our Grand Round speaker for today. Dr. Lardizabal is Professor of Medicine at New Jersey Medical School, Executive Director of Rutgers Global Tuberculosis Institute, which is one of 4 tuberculosis centers of excellence of the CDC, and New Jersey State TB Program Medical Consultant. He has an extremely broad experience in clinical and programmatic aspects of TB control and prevention, and has carried out several research projects funded by the CDC, USAID, NIH. He's conducted these studies both domestically and internationally, and has worked around the world, including in Central Asia, Mexico, Philippines, and the US-affiliated Pacific Islands. He really has focused on improving our understanding of the immune mechanisms behind TB latency and reactivation, and how understanding this is really important in terms of controlling TB. His research primarily focuses on the immunological responses, as we were talking, paradoxical in many cases, of MTB infection, which can help us with diagnosis and prevention. He also is evaluating and studying new tests for tuberculosis, as well as treatment shortening regimens for latent TB and drug-resistant TB. I'm going to stop there and introduce him. So thank you so much for coming.
Hi, good morning, everyone, and appreciate the introduction and the invitation to speak here. So this morning we're going to discuss a fairly rare topic, tuberculous meningitis. It's an ancient scourge. We've made some strides, but we have a lot more work to do to improve the outcomes of these devastating disease. I have no conflicts of interest to disclose. I'll start with this photo here. Some of you may recognize him. If you don't, this is Dr. Robert Koch, who was the father of really microbiology. And about 144 years ago, he announced the discovery of the agent that caused centuries-old human scourge called consumption, phthisis, the White Plague. It was Mycobacterium tuberculosis. That was March 24, 1882. And that was yesterday, also March 24th, and it was World TB Day yesterday. It's the day that was chosen to really reflect on the progress and the challenges ahead when it comes to tuberculosis. So despite how old or how quaint you might think of TB as a Victorian era problem or industrial age problem, it's still a major problem today. So here are the heat maps across the world from the WHO. The dark green areas are the hottest spots for tuberculosis. And you can see the main areas in the globe is in Asia and sub-Saharan Africa, South Asia, Southeast Asia, and East Asia, primarily China. So for 2024, 10.4 million incident cases, that's newly diagnosed or registered cases of TB globally. That's not including the undetected, undiagnosed cases all over the world. We have 2024 numbers. And usually it's at the end of the year towards the fall that the WHO releases 2025 or the prior year's numbers. As far as mortality, still a leading cause of death in terms of infectious diseases globally, 1.2 million in 2024. So those are still very large numbers. And we know it's a treatable, diagnosable disease. Why are we still losing millions of individuals around the world? To summarize what's going on from the WHO global standpoint, still an ongoing global health emergency, global epidemic. The top 5 contributors in terms of numbers are from India, Indonesia, the Philippines, China, Pakistan. From Africa, the big contributors are Nigeria and the Democratic Republic of Congo. We've made progress over the last 2 decades bringing the incidence rates down, but COVID-19 5 years ago certainly broke that trend or slowed it down. And then last year's funding cuts that have affected a lot of programs, a lot of research around the world are certainly going to impact our morbidity and mortality in the next several years. How are we doing in the US? Well, yesterday, the CDC released the numbers. It's 10,260 cases across the US for 2025. That's down from 10,390 in 2024, which is a 1% decrease. What this 1% decrease from the previous year implies is still under scrutiny, partly maybe relating to closing of borders, which really brought down some of the incidence of TB, but not all. What we need to remember is most of our cases in the US come from people who have lived here for many years, progressing from TB infection to TB disease. It's about 80%. I think that's an important bullet to remember. It's reactivation rather than recent transmission. How are we doing in New Jersey? Still an upward trend. Actually, the 360 for 2025 was revised yesterday to 365, which is more than 5% increase from 2024. So along with New York City, places like Florida, Texas, California, we are in the higher incidence areas compared to the rest of the US. And that's also an important aspect to remember. When we break it down in terms of the counties, Middlesex County, where we are today, has consistently been in the top 4, top 5 over the last decade or so. Several years ago, it occupied the top spot for at least 2-3 years, but it's now tied with Bergen County. Despite the fact that Middlesex is down, the other surrounding counties like Mercer are up, and many of the patients that you may be involved with may come from these surrounding counties as well. Moving more closer to our topic this morning, let's break down the sites of tuberculosis disease in the body. As you can see from this pie chart, this is from data out of 2024, 71% involve the lung primarily, and 30% or so are extrapulmonary. Among this 30%, about 10% of that group will involve the lungs concomitantly. And then zooming in down to the brain or the central nervous system, meningeal TB accounts for 5% of extrapulmonary sites. So it's really shrinking down in terms of number, which is a good thing. It's about 170 average per year, but its impact is huge. And so with that, I'll start off with an actual case that presented to a suburban Essex County hospital just a couple of years ago. There's a 53-year-old male who presents with lethargy, altered mental status, nausea and vomiting, ataxia, severe headaches, unrelieved by strong analgesics. He's been having these complaints for 2 months and has been progressing, presenting to ERs with workups that have been negative. CAT scans were negative. He has a history of hypertension, otherwise nothing else remarkable in his past medical history. He's a construction worker who was born in El Salvador and has been living in the US for about 8 years. The examination reveals slightly elevated blood pressure, Primarily, findings are centered on his neurologic exam. He's encephalopathic, he's confused, he has no focal deficits, he has no cranial nerve palsies. In terms of lab work, he has a sodium of 122, decreased serum osmolarity to 265. The rest of the lab work was unremarkable on admission. They proceed with a contrast-enhanced CT of the head, which now reveals hydrocephalus and leptomeningeal enhancement on the CAT scan. So that triggers a meningitis workup. Lumbar puncture has an elevated opening pressure, elevated lymphocytes with predominant elevated white count with lymphocytic predominance, and treatment for meningitis is started, consisting of vanc, ceftriaxone, acyclovir. His hyponatremia is likewise addressed with 3% saline. On day 3, his MRI now shows multiple strokes in addition to the hydrocephalus. Neurosurgery is called in to address the hydrocephalus because of worsening mental status. A ventricular drain is placed on day 4. All steroids are started for presumed vasculitis or concern for vasculitis. The next bullet shows the results of various serologic workup for both for infectious diseases and connective tissue diseases, which came back with negative results. So now we're about a week into the hospitalization, and his conditions worsening. Somehow by day 7, somebody ordered a quantiferon. This came back positive, and that triggers another lumbar puncture, trying to look for tuberculosis at this time. Day 11, CSF PCR is positive for MTB. He started on RIPE, rifampin, INH, pyrazinamide, ethambutol. He's progressively worse. His regimen is modified to increase dose rifampin administered intravenously, plus amikacin, levofloxacin, linezolid, and the other first-line drugs. Unfortunately, by day 17, brain death is confirmed by nuclear scan brain perfusion. So it's an unfortunate situation. A healthy construction worker doesn't make it through this TB meningitis infection. And the key problem wasn't recognized until too late. So time is brain for many causes, especially for TB because it's so hard to find. So globally, mortality is about a quarter of people with TB meningitis, certainly higher among people living with HIV. And among those that are fortunate enough to survive, a third of them are left with permanent neurologic disability. So it's a big, devastating problem for people who are afflicted with it. So what goes on here? Why is there such a bad outcome? Well, it starts with an infection of the lung, right? TB enters, portal entry is the lung. Primary infection is established in the alveoli. Macrophages sort of phagocytose the bacilli and attempts to initially start that control mechanism, cellular mediated immunity. But during this time, as the body is trying to figure things out, there is a period that this infection disseminates hematogenously and lymphatically, and it may find its way to different parts of the body, and then for today, it's the brain, right? So it gets to this area up here in the cranium, and it's confronted by the blood-brain barrier, which is kind of hard to penetrate, and that's protecting the brain. That somehow MTB is able to cross by itself through the blood-brain barrier. Another mechanism is via this Trojan horse mechanism wherein an infected macrophage is able to push through the blood-brain barrier and get into the parenchyma. Once it's in there, the microglia are the protective cells of the brain, starts its own sort of immune alarm, calling in chemokines, cytokines, and then the whole process of granuloma formation begins. So this is these granulomas that form in the brain are often referred to as rich foci in the literature, just historically described by a physician, Johns Hopkins, in the 1930s. The ones that are located like in the periphery somehow over time may rupture into the subarachnoid space and then releasing the proteins in the bacteria into that space, triggering TB meningitis. Now it's this response to the presence of bacteria in the subarachnoid space that triggers this, really devastating inflammatory effect, inflammatory response. Very thick exudate is formed, and because of the anatomy, you can see this lateral view of the brain. Around this area is the fluid, and then because of gravitational forces, this thick exudative fluid settles in the basal cisterns. It's this area that you find a lot of different structures: circle of Willis, the MCA, the middle cerebral artery, pituitary gland, and the cranial nerve. They're all down here in this basal area of the brain, and this exudate is just clogging this drainage system up and wrapping itself around the vessels. So there's this, the branches of the middle cerebral artery that get deep into the brain parenchyma, which are primarily affected by this exudate, causing it to progress into vasculitis and sort of subacute episodes of stroke. This is not like a large MCA stroke where you can kind of remove that clot. It's this sort of vasculitic process that just keeps going on for weeks until it gets really bad. So that's what happens in TB meningitis, and that's why the end result is always devastating. How do we diagnose? Well, let's recognize it, first of all, that the risk is there. It's a subacute process that progresses from a prodromal phase of headaches and fevers and fatigue to coma, right? The common presentations are usually in stage 2, where they're confused, they're lethargic. They may have cranial nerve palsies, that's usually cranial nerve 2 and 6, so affecting vision and lateral movement of the eyes. In terms of workup, the lab, hyponatremia might be a flag. Hyponatremia is present in about 35 to 40% of people with TBM, and so use it as a potential signal. CSF obviously is an important part of your workup. You will have an elevated opening pressure. Cell counts will be elevated. A big clue may be the lymphocytic predominance of the differential of this cell count. The protein will be up, glucose will be down. Consider adding adenosine deaminase as part of your CSF workup if you are considering TB meningitis. Again, you have to have that in your differential in order to proceed, right? Bacteriology smears, AFB smears for the CSF have low sensitivities. Don't hang your hopes on your smear. Being negative means very little. It's a little better for cultures and for liquid media. Nucleic acid amplification tests are crucial in establishing the diagnosis, as you saw with the case I used, with about an 82% sensitivity. And this is the GeneXpert MTB rib, which I believe your hospital uses as well. Another aspect of NAT that you might want to consider using is the cycle threshold, which is how many times this machine is amplifying to detect the nucleic acid. The lower the cycle threshold, the higher the bacterial burden. So it doesn't have to work much to find the nucleic acid of MTB. So that's a good way to kind of figure out what's going on in terms of what you're dealing with. Imaging is important. CT and contrast-enhanced CT is helpful as a beginning. You'll see hydrocephalus or leptomeningeal enhancement, but you see more in the MRI. So on the left side of the screen, the top panel, A is the normal MRI, B is an MRI showing the basal exudates with those vessels coursing through it, where the arrow is. The middle panel is hydrocephalus that improves with treatment. The lower panel are various manifestations of tuberculomas. On A, you have ring-enhancing lesions, and B, you have a big parenchymal abscess. On the right side, you might be able to identify infarcts better with an MRI. And down on the farther side is how a swollen brain might look like. You lose your sulci. This table just summarizes all the available tests we have currently. I'm not going to read through this, and I'm going to have Kirsten have PDF available if you want it for reference. But just want to go to the expert MTB-RIF portion here. This was actually developed at Rutgers, New Jersey Medical School, investigators there, taken over by company Cepheid, and is currently marketed by Cepheid. The same investigators have improved MTB-RIF and have given it a new generation version, which is called MTB Expert Ultra. It's a very big improvement in sensitivity. And you can see here for MTB-RIF, the level of detection, it requires 116 organisms per ml. But for Ultra, you only need 16 organisms per ml. So, TBM is paucibacillary. So, the easier it is for the platform to find it, the better. However, we're not, MTB Expert Ultra is not available in the US. It's available since 2017 everywhere else in the world, but we don't have it, and it has something to do with FDA approvals and the cost to get through that gauntlet here in the US for such a low incidence country. So we don't have the benefit of newer technologies, actually, that were developed here. How do we manage TB? It's three-pronged: anti-tuberculous, the management of the immune response, and then the management of brain injury. Much of this will focus on the anti-TB treatment for the next 10-15 minutes. So standard treatment, HRZE, ionate rifampin, pyrazinamide, ethambutol, really extrapolated from the treatment of pulmonary TB. The only difference is longer, a total of 9 to 12 months. So this guideline is an extrapolation, presuming that they'll do well just the same, just keep it longer. The recommendation likewise is to use adjunctive corticosteroids across the board if the diagnosis is TB meningitis. Similar recommendations from the Academy of Pediatrics, the Red Book. The only difference here is they take out ethambutol and replace it with either levofloxacin or ethionamide. Ethionamide is an analog, structural analog of isoniazid. It's very good penetration into the brain. So pediatricians recognize the advantages of using these drugs as opposed to ethambutol and put it in their guidelines. I use this Kaplan-Meier to illustrate the importance of isoniazid and rifampin, and this is published back in 2017 and looks at a cohort of New York City patients with TB meningitis and the effect of isoniazid rifampin and isoniazid rifampin resistance on mortality. The solid line is no resistance. The next line down is isoniazid resistance. The next line down is rifampin monoresistance. And the bottom line with dismal results are people infected with MDR strains, both INH and rifampin resistant. So it's just sort of a clear sort of description of how important rifampin and isoniazid are in the treatment of TB meningitis. There have been many studies looking at CSF concentration of these two important drugs. INH does well, it gets into the CSF very well. But the problem with rifampin is it doesn't get in very well. And it was a concern, that it's very far off the serum levels when they check the CSF levels of rifampin, just hovering slightly above the MIC. So obviously, people thought that maybe we need to do more with rifampin. How do the other first-line drugs do? Pyrazinamide gets in well, and fluoroquinolones get in well. Aminoglycosides and streptomycin doesn't. As a matter of fact, back in the days when we were treating TB meningitis with streptomycin and isoniazid and PAS, they needed to administer it intrathecally because it doesn't get there. And so they just go direct into the CNS and give it there. So that's just a good example of how bad it gets in there. So not a good drug for CNS TB. So is our current treatment based on the guidelines suboptimal was a big question for the last 10 years. We know that with the standard 10 milligrams per kilogram rifampin, majority have positive outcomes, they do respond. But could we do better with by raising CSF levels of rifampin was the big question for up to now. We know INH is good, PZA is good. Can we do better with rifampin is the big question. A lot of studies have looked at tolerability and efficacy using models regarding higher dosing of rifampin. So trials have shown that raising it to 20 to 35 milligrams per kilogram dose does hasten sputum culture conversion in pulmonary TB and has been shown to be well tolerated. In other studies, 30 milligrams per kilogram doses increases the CSF levels that exceeds MIC, without increasing adverse effects. And other PK-based models have shown that it might even decrease death, the risk of death, or increase survival, as you can see in the bottom graph. The red line is rifampin given at 1,350 milligrams PO. So these are all models and small phase 2 trials that show maybe it's good. But when you bring it out there into actual clinical trials with human studies who have the actual disease, there have been mixed results. Ruslami in 2012 used IV rifampin, 13 milligrams per kilogram with or without moxifloxacin. They showed a difference here. Bear in mind that she had 60 patients at that time. A few years later, Hemskirk did a trial with 800 plus patients. Oral rifampin this time, 15 mg per kg with levofloxacin. And you don't see the separation here between the intervention arm and the standard treatment. So what's going on? More trials went to kind of continue to answer this question. The next three are the most important recent trials looking at higher dose rifampin. TBM Kids, published in 2022, looks at high-dose rifampin with or without levofloxacin for pediatric population. In 3 arms, 30 milligrams per kilogram ethambutol with INH and PZA, 30 milligrams per kilogram levofloxacin, and then the standard 15 milligrams per kilogram rifampin. And what did they find? They measured by using modified Rankin scale, which is kind of the neurologic status of the kid, as well as neurocognitive assessments with MSEL, early learning scales. And what they find, there's no difference in the recovery between both the intervention arm and standard treatment. The only difference they noted here was better neurocognitive outcomes in the higher dose rifampin arm. I'm not sure what the signals or what the message is with this result, but it's the first time, again, that high dose rifampin isn't giving you major benefit. This is an important study, the Harvest trial that was published last December. To me, it's a big, important landmark trial when it comes to TB meningitis. Here it's clean. They just use 35 milligrams of 35 milligrams per kilogram rifampin, as opposed to standard 10 milligrams, and everything else is the same for the intensive phase, which is the first 8 weeks. And their primary outcome, mortality at 6 months. And what did they find? No difference. As a matter of fact, there's a trend to worse pattern in the higher dose rifampin. So our previous assumptions based on models and animal studies and all that isn't bearing out when we're doing big trials. And these are hundreds of people, 400 plus, right? So the thinking here when trying to explain why such is perhaps these high levels of rifampin is interfering with the benefit of dexamethasone, increasing the washout, the metabolism of steroids. So more to come. The short trial is another pediatric trial, children between several days old to less than 18 years was enrolled here. And the interventional arm, as you can see here in the abbreviations, it's HSINH 20 milligrams per kilogram, rifampin is 30, pyrazinamide is 40 milligrams per kilogram, and levofloxacin is 20 milligrams per kilogram, given straight through for 6 months. That's a totally new way of doing it. And they compared it to standard, intensive phase, continuation phase treatment for 12 months. The second randomization was whether aspirin helps them, 20 milligrams per kilogram. What did they find? The shorter intensive regimen was not better, was not even equal to standard. And the second big message from this short trial, which was rolled out in the recent World Conference and still yet to be published, is that aspirin didn't help in this study. So more messages that are sort of contradicting conventional wisdom. So that's the story with where we are with rifampin. Spend a minute focusing on isoniazid. There are people out there asking whether we could do better with this all-important INH. And as some of you might know, there are some people who are called rapid acetylators and some people who are slow acetylators or metabolize INH slower. The slow ones are prone to liver injury, and the fast ones probably don't get the full benefit of isoniazid. So there's this NAT2 gene that's essentially the controlling mechanism in terms of acetylation, and there are assays that can determine where you fall in this spectrum. And so they're carrying this out in China, hundreds of subjects, And they're going to answer the question whether higher dose INH benefits the rapid acetylators. It's kind of known in the literature that East Asians tend to be higher acetylators. That makes sense. They're trying to look for them there. How do second-line drugs do? Well, the three bottom, I've already covered the aminoglycosides, not too good. Limited access to CNS and decreasing access as inflammation of the meninges improves. So not the first go-to to think about when you want to use second-line drugs, but ethionamide, which is an analog of INH, is good. Levofloxacin, moxifloxacin is good, CSF to serum ratio, and cycloserine, which is an old standby second-line drug for MDR-TB, gets to the brain well. I'll touch on this BPAL regimen. So BPALM consists of bedaquiline, pretomanid, fluoroquinolones like levofloxacin and moxi, as well as linezolid. All of these drugs get into the CSF well, except for bedaquiline. And so it's been felt that BPAL should be used with some caution when we're dealing with TB meningitis. What do we do if we can't use the standard treatment? Doesn't mean we can't use BPALM, because we know that the components of BPAL are good in the brain, and in animal models, pretomanid together with pyrazinamide has excellent bacterial killing. So perhaps we can augment BPALM with other agents such as pyrazinamide and cycloserine if we need to use this regimen. I'll just bring this to your attention that there are these studies that are looking at higher dose rifampin and linezolid, both the ALTER and SIMPLE studies in Uganda and Indonesia. We'll answer whether it helps or not. Anti-TB therapy plus adjunctive therapy studies are being conducted in Africa, the INTENSE and LASER TBM trials, looking at high-dose rifampin, linezolid, and aspirin. So more work is going on out there. So I'll move to the next branch of our management, which is immune modulation. We use corticosteroids, primarily dexamethasone across the board, higher dose to begin with worse initial presentations. So 0.4 milligrams per kilogram per day for at least the first 2 weeks or so, maybe all of the first month, until things are kind of cooling down. And then you start tapering by 0.1 milligram per kilogram per week. So this is what we do for everyone, and that's what's in the guideline. And it's an offshoot from earlier studies. This is early 2000s. Flights really showed among all patients who were non-HIV positive that there was some survival benefit when dexamethasone was used. That kind of led to our practice today. Other investigators looked at host genetic factors because we're not all the same in terms of the way we handle infections and how we respond with inflammation. So he used zebrafish models, zebrafish embryos, infected them with M. marinum, and studied the different genotypes of this LTA4H promoter gene. This gene is essentially the thermostat that controls our inflammatory response. And based on your genotype, you may be a homozygous TT, which is the hyperinflammatory genotype, or the cold responder, which is the CC homozygous genotype, under response inflammatory-wise, and so the bacteria continues to progress. So I think it was nice to recognize this, that there are differences genetically that control our immune response. The sweet spot are the heterozygotes, the CT, and so they just had the right amount of inflammation and bacterial control, right? So from zebrafish models, he went and looked at people and did their genotypes. A is everyone, all patients, and you can see the CT, the green line, did best. In the middle graph, the red dots are the TT homozygotes, and they had higher white count in the CSF, so more inflammation. And then when we looked at the effect of dexamethasone across the board, not much difference in terms of survival. But when he broke them down in terms of the genotypes, without dexamethasone, the TT or the hot responders did worse. And with dexamethasone, the under responders did worse. So it was a nice signal. Maybe we need to refine our approaches based on the host. Other studies proceeded from there. Vietnam, HIV positive on the left, HIV negative on the right, and the differences between the response of the TT in the setting of HIV infection. So that was another variable. Everybody gets dexamethasone here. The bottom, interestingly, separated out by severity of disease. The ones that presented with worse GCS seem to benefit more with dexamethasone if they were TT. So a lot of these different, and sort of how do we interpret all these results? We need to keep going to understand this further. So in terms of steroids, there are RCTs that are stratifying LTA4H genotypes out there with and without HIV, and they're underway in Vietnam. The next modulator is aspirin, which I mentioned briefly with the SURE trial. And here it's also part of the inhibition of this cyclooxygenase pathway of arachidonic acid metabolism. And we know that it affects the production of prostanoids, which affects inflammation and thrombosis. So theoretically, it should be good in this setting. And phase 2 trials have shown that it may be good, but as you saw with the SURE trial, there was no benefit. So again, there are studies that are ongoing that will look at answer this question further in adults. Mentioned thalidomide, which is a TNF antagonist. Case report showing benefits out there at low doses, 3 to 5 milligrams per kilogram, particularly with tuberculosis. But evidence is inconclusive. A lot is anecdotal. Clinical trials are needed. And these are the trials that are out there looking at immune modulation and stratifying with HIV status, as well as looking at the benefits of aspirin. Biologics, infliximab, case reports of benefits from infliximab, especially with refractory cases. They're on steroids for a long time. And anakinra, which is interleukin-1 receptor antagonist, used for paradoxical reactions. Again, these are case reports, and benefits in these case reports have been described in refractory cases. But again, it needs to be tried, and we need to determine when its best use is. So I'll finish this part with the need to understand the cold responders, the hot responders, and the middle ground. Perhaps the hot responders really need to tone down the response, steroids. The cold responders, we need to support them, boost their response, supportive care, boost their nutritional status, and maybe some other ways in the future. I think this is the model that I want to leave you with, that maybe we could do better by tailoring our approaches and getting more into precision, genetically directed treatment of patients. The last slides, we'll just touch on the importance of neurocritical care. And on this left side are the manifestations of TB meningitis. Hydrocephalus, you need to relieve this increasing pressure. And if it's non-obstructing hydrocephalus, you might start off with acetosalamide or some diuretics. If it's obstructing and there's no response to steroids, you need to drain. So external ventricular drain is frequently used here, draining the third ventricle or the lateral ventricles to relieve the hydrocephalus as you treat the inflammation. The problem here is really the clog, the thick exudate that's really blocking. And once it's there, it's there. You need to kind of like rotor it or something, right? But it's the consequence, and that's a problem. Seizures are frequent, and maybe a meningeal irritation or development of tuberculosis. The approach is variable. Generally, you have to control this to limit brain injury. Sedate them, use Keppra, keep them cold. Hyponatremia, tricky problem, right? And it's the difficulty for the clinician. Is this SIADH? Is this cerebral salt wasting? And in this situations, TBM, frequently cerebral salt wasting is the problem. Kidneys dumping sodium because of signals from the brain, water follows, hypovolemic state. As opposed to SIADH, you withhold fluids, right? It's important to keep them well hydrated, the volume repleted, because you want the perfusion through the sensitive brain to be optimized. So that's a tricky part, how to approach hyponatremia. Infarcts, can we prevent it with aspirin? Is a question. Tuberculosis, no trials, but as I mentioned earlier, thalidomide has been beneficial in some case studies. Finally, how do we monitor elevated intracranial pressure? Easy access to POCUS, optic nerve sheath diameter measurements, very easy to do in the bedside, takes a little practice, but it's there. I mean, all of these things put together equals better outcomes for the critically ill patient with TB meningitis. So I'll end with the unanswered questions. For pathogenesis, what are the different mechanisms involved with different manifestations of this infection? Vasculitis versus tuberculosis versus hydrocephalus. Some go this way, the others go that. There must be an explanation pathogenically why that happens. We need to understand that better. Diagnosis, can we do better with pathogen-based testing? And does host response-based testing have a role in diagnosis? Basically, a genotype profile of the person. For antimicrobial therapy, the question still remains, what's the optimal dose of rifampin? Should we adjust isoniazid for rapid metabolizers? How important is linezolid and levofloxacin in TB meningitis? The studies that are out there ongoing will hopefully answer those questions. In terms of adjuvant therapy, should dexamethasone be stratified by HIV and LTA4H genotype? Again, studies ongoing. Likewise, what the role of aspirin is. And finally, in terms of outcomes, is AI perhaps a very important tool moving forward that might help us improve prediction of response and outcomes? So with that, I'll have my conclusion slide. Prevention is important. Bear in mind that in the US, 13 million individuals have TB infection. Let's prevent it before it gets to this point. I think that's what we all can do. Morbidity and mortality from CNS and spinal pathology from TBM continues to remain high in 2026. We can improve outcomes with early diagnosis, optimized antimicrobial management, nuanced host-directed therapy, and expert neurocritical care support. Recent and future well-designed randomized controlled trials should and are expected to improve outcomes further moving forward. So with that, I'll end my talk and open up the floor for questions. QR code is for consultation if you have problems at the hospital. Yes?
Oh, thanks. Excellent talk. Just one of the clinical conundrums that we're faced with is whether or not to start empiric treatment for TB meningitis. And I think there's just a hesitance because it's, standardly it's 4 drugs that we're starting. A lot of times these patients aren't taking orals. And, sometimes we can't get an LP, or sometimes we get the LP, but it doesn't rule, it's hard to rule it out absolutely. So just any tips that you can offer for the group?
Yeah, that's why it's a challenge. I think, should I repeat the question for the? Yeah, the question is when to start empiric treatment in the absence of confirmation, and I think that's the biggest hurdle. But the way I look at it is, I have to first assess the probability of TB it being part of the picture, and we know that 70-80% of TB cases are from people born outside the US and high incidence countries. That's the first important recognition you should start with. Then move from there. If you have a positive IGRA, fine. That's another supportive fact, but don't use that as a rule out. As with all the tests that you have to be able to distill all of the information, the subacute nature of the disease, the sort of slow progression over weeks, and then say, let me at least cover for tuberculosis until while I'm continuing my workup. The impact is worse if we don't. So the sooner you intervene, the better off the patient is. So there's less to lose by using the drugs and going that route, rather than finding yourself in a stuporous state and not being able to reverse that anymore, right? So I showed you all the different sensitivities of all the tests, even at, nucleic acid amplification tests, like 80%. By the way, for the CSF to be informative, use higher volumes. Go above 5, go 6 to 10. There's more to work with in terms of these amplification tests and cultures. So I think that's another way to kind of improve our yield. But I always say I'm not afraid of the drugs. I think let's just use it until we sort things out.
Hi, just going back to the pathophysiology of how TB meningitis forms. Is TB meningitis similar to pulmonary TB, where immunocompromised and then sort of the disappearance of the granulomas is disseminating the TB, or is, like you said, the tuberculomas in the periphery of the brain causing shear, and is there a mechanical release of TB?
No, it's also the same mechanism wherein that granuloma breaks down for some reason. The CD4 cells somehow are unable to keep that wall up, and then it just breaks down and releases the bacteria within it. Sometimes it's just direct invasion, wherein somebody's severely compromised, miliary TB. It just goes there straight off without that step of granuloma formation. But most go through that step, contain it, stay quiescent, and then somehow breaks down the road.
is the regimen for TB meningitis sufficient to treat systemic TB, or do you have to be looking for other manifestations of TB in the body?
I always say yes, right? Any kind of extrapulmonary form, make sure you're checking the lungs, because that's where it's most commonly present, right? Sure, you might find other areas in disseminated TB, abdominal adenopathy, omental thickening, things like that. So it depends on the condition of the patient. Severely compromised, and you're thinking disseminated hematogenously, it can be anywhere.
Sorry, one last question is just, why were there so many studies being in the pediatric population for TB meningitis, and why does it seem like some of the initial results are from the pediatric population and the planned in-process studies are in adults?
That's a good question. I had that in my mind too. Why always peds, right? But I think one is the impact on infants and the pediatric population. And it's, TB in this population is usually in that form. It's generally sort of extrapulmonary meningitis form, and that's probably the main reason. Adults get into the reactivation part of things, right? They get golden up, and maybe that's one of the reasons.
Thank you. I think we've got one last question.
Thanks so much for a great talk. I think we've all known that HIV is a key predictor in prognosis and so forth. But I was surprised by I think it's great, the data about the inflammatory genotype, but I was surprised by your question as to whether we should be stratifying our treatment based on the presence of either of those. Is there something you didn't share with us? It seems like that the answer to that should be absolutely yes.
Yeah, no, the HIV positives didn't show as good a response with dexamethasone when you stratified the three genotypes. The benefits of dexamethasone in the hyperinflammatory group was clear in the non-HIV positive, but that benefit disappeared in the HIV positives. And so they need to kind of sort things out more in this upcoming studies that stratify everything.
So we're planning 2x2
Yeah.
factorials?
Yeah, so they're going to stratify and see. It's got to have some effect, and I'm talking about not well-controlled HIV. I look at well-controlled HIV as essentially like normal subjects. So they're all being carried out in high-incidence settings. And I think the big message really here is that the important component in this situation is the host response. And I think we will do better by understanding this process more going into the future.
Wonderful. Thank you so much for the talk.
All right, thank you.
Appreciate it. It sounded like there were a couple of things that I think your email. Oh, your email's still up, and I was worried that I was going to keep going.